I'm going to present to you on the latest data from UNAIDS on what's happening with infants, children, adolescents, and women. Before I start, I want to recognize the hard work that goes into producing this data from the country teams that are around the world. We have data from 172 countries right now in the estimates, and they produce the models as well as pull that data from the health information systems in order to produce this data. So I just want to acknowledge them. So let me just start with some high-level numbers on what's happening globally with children. We estimate that about 1.7 million children are living with HIV globally, and that's in the age group 0 to 14. 54% of those children are on treatment, and because of that low coverage, we still have 99,000 AIDS-related deaths in 2020. We estimate that about 1.3 million HIV-positive women are pregnant in 2020, and only 84% of those women are currently receiving some sort of treatment. Again, as a result, we have about 150,000 new child infections in 2020. So before I go into vertical transmission, I'm going to talk for a minute about treatment among children and adolescents. And as we've seen in the past, we continue to have strong disparities between adults and children. In this graph, I'm showing you the treatment cascade for children on the left and adults on the right. And as you can see, the knowledge of status, the number on ART, and the viral load suppression are considerably lower for children as adults. If we look at the center bars there, the proportion of children on ART, as I mentioned before, was 54, while adults, it's 74% of all adults living with HIV are on treatment. So an important gap there. What's upsetting, though, is to see that that gap exists across countries, from countries like Angola to Nigeria to Uganda. You see these continued wide differences between what's happening with children and adults. What was most upsetting this year was seeing for the first time the number of children receiving treatment actually declining. So the absolute number, nothing to do with MOS, this is the data coming from the health information system on the number of children absolutely receiving treatment. And what's so shocking is we know that children will be aging out, but yet we still have 46% of all children living with HIV that are not on treatment. And so that gap and the fact that the number is declining is a real problem for us. So if we look at those roughly 800,000 children that are not on treatment and living with HIV, we know that 70% are in 11 countries. The first country there in that bar on the left is South Africa. We know that's the country with the highest burden, also has incredible resources in order to find these children. So we're hoping that they push forward and try to identify these children and get them started on treatment. The next country there is Nigeria, and I'll come back to Nigeria in a few slides, but an important gap of over 60,000 children living with HIV that are not on treatment. In the right-hand side of this slide, I'm showing the distribution of the children that are not on treatment by their age groups. And you can see that the ages 5 to 9 and 10 to 14 are about 63% of all of those children that are not on treatment. And I think often the perception is that the children that are missing from treatment is that young age group. But in actuality, those are older children who will be harder to find and identify. I want to have a quick call out for my colleague, Chloe Teasdale, who will be presenting on an analysis that we've done of surveys, looking at the distribution by age group of children that are not diagnosed. And that matches very well with this graph that we're showing from the health information system data on children not on treatment. So a good kind of comparability of those data showing that they both show similar results. So just taking a moment to talk about adolescents. This is one of the first years we've had good data on adolescents. And so what I'm showing here is data from 19 of the priority PMT-CT countries and that had good data on adolescents. And what you see is the blue bar is the children living with HIV or adolescents living with HIV by age group. And the orange is the number of those children in that age group that are on treatment. What I want to stress here is that in these older age groups, 10 to 14, 15 and 19, there's a really large number of children that are not on treatment. So the absolute magnitude is quite large in these groups. Keep in mind that among the 15 to 19-year-olds living with HIV, about 55% will have been infected perinatally. And so those children have been, adolescents have been kind of infected with HIV for a long time and should have been identified by now. It also means that 45% are recently infected and might be a little bit more difficult to find. So just recognizing that large magnitude of effort that's required to reach the adolescents. So looking at testing and how do we make sure that we identify children and get them started on treatment. We know that early infant diagnosis and the recent shift towards point of care early infant diagnosis will be critical to close some of the gaps that we're seeing. Globally, we still see about 63% of HIV-exposed infants have been tested by 6 to 8 weeks of age. Eastern Southern Africa slightly higher at 74, but Western Central Africa is the really troubling region here, where there's been a decline in early infant diagnosis in 2020, perhaps due to COVID disruption. I think in our global report that UNAIDS is putting out just this week, there's a lot of good information on what's going on in West and Central Africa, and tips on, not tips, but policies that need to change in order to make sure that we're reaching children, but also reaching mothers to prevent onward transmission. And some of those include removing user fees, ensuring HIV testing at ANC, or at least some sort of some sort of identification method to make sure that you're testing the women that are most at risk. And then a real focus on key populations. We haven't seen that so much in the past, especially at antenatal care, but we need to make sure that we're picking up the support in the ability to make women who are key populations not feel stigmatized or discriminated against when they're coming into those facilities. In addition, removing punitive laws will help that ability for women to not feel stigmatized or discriminated when they come into the ANC. Finally, we need to strengthen our data systems to really match those mother-baby pairs and watch them over time to make sure that those children are being tested. But so once we've gotten through the testing and we've gotten through the treatment, what's unfortunate is that we're still seeing very low viral load suppression, even among those on ART. So in my slides here, I'm showing on the left-hand side, among all people living with HIV, adults on the left, children in the middle, or on the right-hand side there, and showing that very low viral load suppression among all children at 40%, compared to 67% in adults. On the right-hand side, I'm looking at the proportion who are virally suppressed among just those on treatment. So we would expect that to be quite high. You can see among adults that is quite high at 91, and a slight increase over time. So 2020 is quite high proportion virally suppressed among those on ART. However, if you look at the children, among those on ART, we still only see 75% are virally suppressed. There's a nice uptick there between 2019 and 2020, but we need that to be higher. With the rollout of dolutegravir, we hope to see that gap closing. So now let me talk for a minute about vertical transmission and looking at pregnant women. I've shown this graph before. I think it's a really important one. It shows in the orange bars, the PMTCT coverage, so the proportion of pregnant women that are receiving some sort of ARVs. The blue line is the number of child infections, and as you can see, that's really flattening. It's 150,000 new infections in 2020. So we'd like to see that line going much further down towards that black dot that was our target for 2020 of 20,000 new vertical infections. We obviously have missed that. We had a 53% decline between 2010 and 2020. But why do these new child infections persist? One of the things we can look at is looking at what we call the stacked bar. In this case, I've got a simplified stacked bar in this presentation. And what we see is that about 35,000 new child infections occurred because a mother seroconverted either while she was pregnant or while she was breastfeeding. So we have clear evidence on what we can do to try to prevent those infections among mothers, and that is, for example, PrEP or counseling of those pregnant and breastfeeding women, or self-test kits for their partners to help them avoid becoming HIV positive themselves. The second category there is about 65,000 new child infections. So the bulk of those new child infections occurring because women weren't reached with any sort of ART during the pregnancy period. I think there's, again, very straightforward interventions that can prevent that, such as making sure that women are tested before they become pregnant, to try to reduce that onward transmission, and to really integrate the services for family planning as well as HIV testing. The next group there, the 38,000 new child infections, are because women dropped off of treatment during pregnancy or breastfeeding. Again, great evidence out there for peer support working for this, or even potentially, I think we'll hear more about this, but long-acting treatment in settings where the women are interested in such an option. Finally, we have about 14,000 new child infections because a mother was on a regimen but did not have a suppressed viral load. So coming up with the optimization to improve those regimens will be critical to close that remaining gap. Thinking about that 65,000 new child infections because mothers did not receive any treatment, this pie graph is showing the proportion of those women that did not receive any treatment by where they're located. So we see 42,000 of those, or 22%, are outside of sub-Saharan Africa. The remainder are in sub-Saharan Africa. About 21% in Eastern Southern Africa, and about 57% in Western Central Africa. But what I'm showing here is if we break apart Western Central Africa to include everything except Nigeria and Nigeria, you see that 24% of the global women who are not receiving ARVs and pregnant and living with HIV and pregnant are in Nigeria. And so the bulk, the whole number there is 47,000, which is bigger than the number of all HIV positive pregnant women that are not on treatment in Eastern Southern Africa. So a lot of work to be done there in Nigeria. This in a time when their number of adults receiving treatment in the year 2019 to 2020 increased by 30%. We're seeing a decrease in the number of pregnant women receiving ART. So again, a lot of work needed in Nigeria to try to improve that PMTCT program. Want to show what we're doing in other countries to really help understand the epidemic and understand the pediatric epidemic and understand how to reduce those new infections, is looking at this more detailed stacked bar. In Kenya, we had a discussion on how can they get their MTCT rate from a 9.7 value down to below the 5% that's needed for the pathway to elimination. So we looked very carefully at their bar. We see that the gray bar is the largest chunk of their new infections, which is mothers who are dropped off of treatment. So with that reduction, they can reduce their transmission rate from 9.7 to 4.0. In addition, they could prevent new infections among pregnant and breastfeeding women. They could get down to an MTCT rate below 2%. So I want to mention briefly COVID disruption. In 2020 and continuing in 2021, we're asking countries to provide UNAIDS data on a monthly basis of how many women received services. So how many women were tested for HIV, how many women that are HIV positive and pregnant were started on ARVs. And you can see this monthly data show very clearly a drop in March and April in a number of countries. But what was great to see was the resilience and the number of countries that actually got back up to their January, February values over the course of the year. So that's good news. What we're not sure about is what's happening with the wave that's rolling out right now, and we're continuing to ask countries to report to us so that we can identify where those gaps are and try to support them. But I think it's important for this group to know where those downfalls are, that they have rebounded, and we're seeing some good progress in closing the gaps, at least for 2020. Finally, some really good news, and that is in June 8th of 2021, there was a UN political declaration on HIV that was adopted and signed by 165 countries. That signs them on to targets that are specific to children and adolescents in many ways. And so this is great news for the work of this meeting here. We also have a global AIDS strategy that was developed by UNAIDS, but many, many partners as well, that helps us understand what we need to do to reach those targets. 3 points that I'll make quickly. I won't read through this whole slide. One is that adolescents are called out clearly in the targets and in this declaration. And so that's great news for making sure that vulnerable period of adolescence is really reached with not only measurements, but also the services that will ensure that we provide the services to those young children and adolescents. The second point that I want to make is that there is an interim target. So I mentioned the 40% of children living with HIV being virally suppressed. There is an interim target for 2023 to reach that 40%, to move it up to 75%. So that will be a real focus for countries over the coming 2 years, I guess, at this point. Another point that I really want to stress here is among pregnant women. And there's a target now to make sure that 90% of pregnant women are on treatment before they become, 90% of women are on treatment before they become pregnant. And that's going to be an important effort to make sure that we are integrating family planning and other health systems to ensure women are started on treatment early. So my key points, takeaway points. It's critical to pick up the pace to ensure children living with HIV are on treatment, but that's going to require creative and efficient testing methods. I think we can see very clearly the gaps in the adolescents and that are not on ART, and the need to think through how we find and start those children on treatment. Viral suppression is still starkly lower in children than adults, but we're optimistic that things will get better as the DTG rollout continues. We see high numbers of vertical transmission still, despite very clear knowledge and understanding of what we need to do to close those gaps. Hopefully, as countries get better strategic information, that will take place. And finally, we have the great news of that political declaration that shows we have the knowledge and also the commitments to succeed. So I hope everyone in this room, can work together to achieve that success. Thank you.